My name is Dr. Charlene Fitzgerald, and thank you for joining us for this virtual press conference. I'm joined today by Dr. Tracy Bridger, past president of the Newfoundland and Labrador Medical Association, Dr. Paul Johnston, a urologist in St. John's, Dr. Carolyn Dobbin, general surgeon in Gander, and Dr. Jerry McGraw, gastroenterologist in St. John's. We've invited you here today to talk about the need for the Minister of Health to publicly release the government's plan for the reopening of services across this province. Physicians and the public must be informed about this plan for achieving normal levels of service and the time frame for dealing with the expanded wait lists that have accumulated during the pandemic lockdown. I'd like to acknowledge our provincial government, the Chief Medical Officer of Health, and indeed the public who have managed the disease to a very low prevalence. The hard work has paid off, and congratulations to everyone who played a role. It's been a success. However, fighting a war is different than establishing a peace. Thus far, public statements about reopening services have been vague generalities. To get to a better understanding of the current situation, we asked the NLMA section heads, some of the most informed physicians in the healthcare system, to provide estimates of current service levels as a percentage of normal service levels. This data was collected between the 20th and the 22nd of June. The data is based on well-informed views of frontline physicians, not on hospital databases, but it's still a revealing portrait of where we stand right now. The picture that emerges is that on average, we are at 30 to 50% of normal volume across the specialties. Family medicine, which is done mostly in private offices, ranges in capacity from 25% to 50% to 75%. Anesthesia at St. Clair's is running 20 to 60, allergy 50%, ENT 20 to 30, gastroenterology 50% in outpatient clinics, nephrology 20 to 25%. Plastic surgery is operating at 25% for consults, 30% for minor procedures, and only 10 to 15% for major surgeries. Obstetricians and gynecologists are at 50 to 60 of clinic volume. Urology, 20 to 25% in Eastern, and 20 to 25% in Central, and 50% in Eastern. It goes on. General internal medicine outpatient clinics, 50%. General surgery is operating at about 30 to 50% of normal volumes. Dermatology, 40 to 50%. Cardiology, 45%. Orthopedic surgery, 20 to 30% in Eastern. Neurosurgery, 30%. Respirology, 30 to 50% for procedures, 10 to 30% for clinics. Radiology at the health sciences is at approximately 60%. Ophthalmology, 45 to 50%. Pediatric surgeries and consults have been cut to half and are limited to emergent cases only. So there's a lot of waiting going on. With this as a starting point, we provided Minister Haggie last week with this data, and we asked him about his plans for reopening the healthcare services, and he told us that he had just directed the healthcare system to reopen to a target of 85% of normal services by July the 6th. We were surprised by this revelation for two main reasons. First, we were unaware of the planning process, and that planning process hadn't involved physicians and to such a target. And second, we were skeptical that such a target would be achievable by July the 6th. Our members tell us that medical services will not return to pre-COVID levels for some time. Many parts of the health system remain significantly below capacity and will likely remain that way for many months. The issue is hospital rules and resources. Physicians who work in hospital settings rely on hospital resources, operating room time, clinic time, and they can't control what time is granted. Regional health authorities control which services are allowed to restart in their facilities, the allocation of resources, the rules around personal protective equipment, the distancing requirements, the number of patients that can be seen. They also require patients to be tested for COVID-19 prior to any aerosol generating procedures. And these restrictions are in place for good reason. We don't argue with these restrictions. They are there to protect staff and to protect patients. We support these restrictions, but they exacerbate the already existing wait lists. Specialists have a backlog of cases, a huge list of new referrals, coupled with significantly reduced capacity in their clinics. Surgeons have been reprioritizing their patients based on level of urgency, but are not able to book additional cases to reduce the backlog because there's already a limited operating room schedule. On top of this, regional health authorities are already moving towards summer slowdown. Summer slowdown means that usually in hospitals, they're running at 65 to 70% during those months. In calling on the minister and the regional health authorities to release their plan, we also call on them to release benchmarks by specialty area so that the public can see what progress is being made towards returning normal. The Nova Scotia Health Authority has an excellent example of updates of volumes of various procedures, the progress being made on those procedures that were canceled as a result of the pandemic. Nova Scotians can access those timelines for when their programs and services will resume and information on the programs their government is making. We need a similar mechanism and an accounting of the healthcare system and the progress we're making. Generic indicators sometimes conceal more than they reveal. For example, the Minister of Health has stated publicly that the hospital bed occupancy in our system is at 70% right now, but bed occupancy has no relationship to the increasing services in such areas as surgical or in particular diagnostic services, which will vary widely by region. The physicians of our province will support this process by working collaboratively and planning with the regional health authorities, by prioritizing urgent cases on their wait list, by reassessing patients, by making themselves available when hospital resources are freed up. Doctors have been triaging their cases for weeks and identifying urgent cases. Physicians in their own private offices will also follow the rules adopted by the health authorities for screening and for social distancing. This means, of course, that the rebuilding to normal levels in private offices will mirror the guidance for the public health system. Physicians already took part in an online engagement consultation by the Newfoundland and Labrador Medical Association to provide advice on establishing priorities for reopening services. We released those recommendations to Minister Haggie on May the 15th, and we've published those on our website. Doctors are ready. We're ready to accelerate the volume of patient services now. Patients' health conditions are going undiagnosed and untreated. Many necessary surgeries and procedures are not occurring. This results in preventable suffering for patients and will lead to an increased strain on our healthcare system. Some provinces are farther ahead than us. For example, the New Brunswick Regional Health Authority reports that they are already at 85 to 90% of normal service. Therefore, we're calling on the Minister of Health to release this province's plan with specific timelines for increasing capacity in each service. as well as data to track our progress. The regional health authorities and the Center for Health Information are well equipped to issue weekly updates on how this plan is progressing. We need clear direction on how we are going to get our healthcare system back to normal. The people of this province deserve open and full transparency about the level of service they can expect to receive from their healthcare system, and they need it now. I'd like to now turn this over to Dr. Tracy Bridger for a few words on how things are where she works.
Thank you, Dr. Fitzgerald. And I would also like to start by thanking the public here in Newfoundland and Labrador, as well as all of the healthcare professionals, clinical chiefs, managers, and leadership teams in Eastern Health and the other regional health authorities. I know that they've been working tremendously hard, and I know it hasn't been easy. We've been working hard since the pandemic struck by seeing as many patients as we can virtually, either via telehealth or on the phone. And when possible, urgent patients are seen in person. Of course, even non-urgent patients need to be seen in person at some point, and some sooner than others because they are becoming more urgent as time goes on. For me, this would include patients who have been seen virtually, who now need to be seen in person in order to complete their assessments. It's difficult to say if a child is growing properly, for example, without having an accurate height measurement done in the hospital, or if a certain pain someone is having without a physical exam, it's difficult to say what might be going on. Of course, these are just a couple of examples. There's many other examples and reasons why we need to see patients in person. Now we are trying to get back to seeing more patients in the outpatient department. There are challenges noted when we are there. Most clinic waiting areas and the clinics themselves are actually shared spaces between physicians and clinical teams. And only so many patients are allowed into the waiting room and to clinics at any one time in order to keep the social distance. Of course, for children and youth, they need to be accompanied by a parent or guardian. So this increases the number of people as well. Clinic appointments need to be staggered more, and rooms, of course, need to be thoroughly cleaned in between patients. All of this means that the number of patients that can be seen in the outpatient clinic at any one time is ultimately decreased. And I agree with your numbers. It's drastically decreased, I would say, to about half or less what we would normally see in person. We're certainly willing to do whatever is necessary for our patients, providing the care that's needed while staying safe. That's all we ever really wanted. Thank you.
Okay, thank you, Dr. Bridger. I'll turn it over to Dr. McGraw, gastroenterologist in St. John's.
Thank you, Dr. Fitzgerald, and I'd like to say thanks to the NLMA and everyone else for the opportunity to discuss this today. I'm a GI physician. That means I look after digestive disorders. And there's really two main aspects to my job, the clinical aspect as well as the fact I do procedures. So I'd like to echo Dr. Bridger's comments about the clinical area. We've started back probably the past few weeks, and we've been up to about 50% of our outpatient capacity. And I do understand that Eastern Health has plans to increase that further. So the good thing in all this is virtual care, and I think virtual care has been a bit of a silver lining. I know some of my family physician colleagues and friends have embraced this, and I've embraced it for my patients as well. And my chronic patients, and I've built up quite a few in the 16 years I've been here, they really appreciate the ability to connect with me. My Crohn's patients and my ulcerative colitis patients, you know, they used to come in 2, 3, 4 times a year to see me. And with virtual care, hopefully it'll persist because we may be able to cut down those visits into the long term. And that might actually free up my time to be able to see new patients, because we've been kind of bottlenecked in GI because so many of our patients have become chronic because we actually don't send our patients for surgeries as often as we used to 20 years ago. The second aspect of my job is procedurally related, and I do colonoscopies and upper scopes. And there was quite a demand prior to the pandemic for these procedures. And we've went through 2 or 3 months now where we've had very little to no procedures. Throughout the entire pandemic, we provided emergency procedures. I work at both the Health Sciences and St. Clair's. So if someone showed up in the emergency department, or if they're inpatient and they needed those procedures, we did it. If a family doctor called us with an emergency, we dealt with it. But there were a lot of what we would call urgent and non-urgent type procedures that haven't been dealt with. We've had, I think, 2,000, maybe close to 3,000 procedures between the two hospitals that were canceled. And right now, we did start back with some procedures in May, probably initially 20%. And then as June came around, we increased to 30 and 35%. And last week, most of my lists were at maybe 50 to 60% their usual capacity. And my colleagues would have experienced the same situation in terms of their volumes at the Health Sciences and St. Clair's. And I understand that even outside St. John's, some of my colleagues have contacted me and they're still back in the 30 to 40% range in terms of their volume. The thing that worries me is that, we've had 2 or 3 months where we've had 0 or 5% of procedures and we need to catch up on those. And now we're looking at a situation where we're at about 50 to 60% of procedures. And even if we do get up to 75 or 80%, we've still got this massive backlog of procedures that need to be caught up on. My procedures are quite sensitive and invasive. If you're going to do an upper scope and look in someone's stomach, you can't socially distance from them. I can't do that virtually, and I can't do it from 6 feet across the room. That means that there's a high level of personal protective equipment, or PPE, that's required to do endoscopy. Most of our patients who are getting upper scopes, they all require either COVID testing now or a higher level of PPE if they can't have COVID testing. So we do realize the implications of that on the healthcare system. And you only have to watch the evening news and see the issues that surround PPE in the rest of the world. So I understand that, we need to have a good supply of PPE in order to be able to proceed with the procedures. In some situations, as Dr. Bridger alluded to, the infrastructure that we're working in doesn't lend itself well to social distancing. So particularly where I spend most of my time at the Health Sciences, our GI unit is quite old. And prior to the pandemic, we'd actually engaged with government and Eastern Health, and we're making some very positive strides. And we're planning on a new endoscopy unit for the Health Sciences, which would have alleviated some of those concerns. We were certainly over capacity here before the pandemic, but now it's almost like an Achilles heel. We have to deal with these social distancing issues in a unit that's far too small, where we did too many procedures for the size of the unit prior to the pandemic. And now we have to, accompany social distancing. Patients need to be picked up. Most patients have sedation when they get procedures done, so they need someone to accompany them when they leave the building. So all these different factors had to be taken into consideration. And it certainly makes for a challenging work environment. And, I'd love to be able to get to 80 or 85%, and I'd love to be able to get to 100%, because at 80%, our wait lists still continue to grow. So those are my concerns as we move forward. In GI, I was very proactive. I've had all my colleagues given them information to reclassify their procedures. We subclassify procedures. My surgical colleagues who do endoscopy as well have done all the same things. We were actually ahead of the curve, and Ontario only announced last week that they were going to subclassify their procedures. We actually did that a month ago. So we're actually ahead of the curve in terms of subclassifying our procedures. But that still leaves us with a number of procedures that need to be done. You can slice up the pie differently, but there's still 100% of procedures that at some point we need to get to. And I'm not suggesting by any means that we get to 100%, because I think in a COVID environment, that's not safe. But we certainly do have an opportunity here to get some work done, because the reality is that we are in a pandemic, and that COVID will eventually get back to Newfoundland. And then we're probably going to have to scale things back again. So, we have an opportunity here to try to get some of our procedures caught up on. Thank you for this opportunity.
Thanks, Dr. McGraw. And now I'll turn to Gander, to Dr. Dobbin, to speak about how things are in Central.
Thank you, Dr. Fitzgerald. And like everyone else, thank you for the opportunity of speaking. I do bring to the table a little bit of a different perspective, being past the overpass. So I have a prepared speech to read. Good afternoon. I'm a general surgeon and chief of surgery at James Peyton Memorial Hospital in Gander. I'm here today to provide my perspective on the resumption of medical services, as I want the general public to understand that the healthcare system that I'm working in is not at 85%. There are many barriers to healthcare provision at this time, including, but not limited to, maintaining a robust PPE supply for our staff and patients, the need for pre-procedure COVID testing for patients undergoing an aerosol-generating medical procedure, availability of public health resources for COVID swabbing, distance to a COVID lab, need for physical distancing, maintenance of empty beds in ICU and on our floors for a possible COVID surge, as well as our human resource limitations. We have been externally controlled by provincial guidelines that have dictated the volume and type of care we provide. As we have moved through the various levels, it has been my experience that we have received these guidelines after we have already moved on to the next level. It has taken time at each level to increase services within the framework that we have been provided. Without clear guidelines, it has been impossible to plan for increasing services at the start of each level. I feel that we've been adrift at sea without a captain, floating around, waiting for a path to follow. That doesn't mean, though, that care has not been provided. Throughout the pandemic, patients with urgent and emergent cases have been and are continuing to be seen and treated. I will qualify that, though, with the ones that we know about. They have been seen through our emergency departments, our clinics, and our endoscopy units. Waiting lists for our operating room, endoscopy units, and clinics were triaged at the beginning of the pandemic, have been re-triaged, just like Dr. McGraw said, throughout the various levels, and new consults continue to be triaged. James Peyton in Gander has a 14-bed COVID ward that remains protected from regular use. The general surgeons, orthopedic surgeons, and hospitalists have been sharing what was customarily our orthopedic ward. Up to this week, we have been performing urgent and emergent cases, as well as some day surgery semi-urgent cases. This week, we have been increased to allow 4 same-day admission cases per week on top of the day surgery cases we've been performing. We would normally do at least 14 same-day admission cases per week amongst our services. These 4 cases must still meet a criteria of expected discharge within a 4 to 5 day window to avoid bottlenecking our system. In our endoscopy unit, we are increasing from our current level of 6 cases per day to 8 cases per day next week. The pre-pandemic volume for our endoscopy unit was 15 to 20 scopes per day. Lastly, our clinics, just like Dr. Bridger said, are hospital-based. Currently, we have been limited to around 45 inpatient appointments to be shared among all disciplines with clinics in that area. The space is small and can be very congested on routine clinic days. As volume increases, we will struggle to meet the social distancing that is required by public health guidelines. As we progress through the alerts in this pandemic, it is important for the general public to appreciate the limitations that our system is facing. Physicians have been working diligently to provide care within the framework that we have been provided. Resumption of services to 85%, while desirable, has many hurdles. A provincial plan with accountability at all levels will be an essential element if we are to meet this goal of 85% capacity. Thank you for the opportunity.
Thank you, Dr. Dobbin. And now we'll turn to Dr. Johnston, a urologist in St. John's.
Thanks, Dr. Fitzgerald. As mentioned, I'm Dr. Paul Johnston. I'm a urology oncology surgeon at Health Science Center. Appreciate the opportunity to speak my mind, and thanks for sharing your time, everyone. I was initially pleased and supportive of the province-wide shutdown of services in the early phases of our pandemic. But more recently, in light of our internationally acceptable infection and death rate, I'm frustrated by the lack of support from government for letting me make my way through my backlog of patients. Until this week, I've been unable to choose my own specific OR cases. This was done for me by various personnel who are not surgeons, who asked me to submit a list of only those patients that I felt were absolutely life-threateningly necessary to operate upon. And then I was told to wait a moment until I could get the go-ahead and figure out which week I could actually do the case, or maybe not even do the case yet. Over the last 3.5 months, I have now accumulated many patients whose diagnoses were not life-threatening initially, and thus were not operated upon, but who collectively are approaching a dangerously lengthy wait time. Based on what we've been allotted by government for COVID level 2 working capacity, going forward, urology in particular will be running at about 50 to 65%. That's a bit optimistic, and government officials are thankfully no longer assisting us in choosing when and which patients to operate on. I respectfully disagree with Minister Haggie, who has stated we are at 85%. I say this to you as a person who works in the trenches and on the front lines of cancer surgery in this province. I cannot catch up in a timely manner given what we have been allotted at present. If there is to be a second COVID wave, it certainly is not here now. We should not be saving our bullets while waiting for a second wave. The time is now to open up OR time and let surgeons catch up as best they can until such time as a second wave arrives, when we may once again be forced to clamp way down on OR time for patients whose diagnoses are, at this point, quite frankly, more dangerous to them than COVID may theoretically be. I'm very frustrated after speaking with colleagues in other provinces whose COVID infection and death rates are far worse than ours, and yet are given almost double the OR time that surgeons of this fine province are given with which to look after our very worthy patients. To Minister Haggie, I say this: please open the OR to something similar to those volumes seen across the country. Give me a chance to catch up before a second wave of COVID theoretically arrives. To my patients, I say this: I have sat or talked with you during this difficult time, and I know that you are laying awake at night wondering when your operation will happen, or your therapy will start, or your CT scan will be completed. I too am laying awake at night wondering the exact same things. It is an honor and a privilege to look after you, and if I could just get to your operation in a timely fashion, you and I could move on with your life and start focusing on the future again. Thank you again for the opportunity to speak my mind.
Thanks, Dr. Johnston, Bridger, McGraw, Dobbin, and now we'll take some questions from the press. Jonathan?
The first question we have is from Brian Medor of VOCM News. Are there missed opportunities to use private medical clinics instead of hospital-based to reduce the backlog?
Well, thanks for that question. Yes, it would be right now a very good time to move as much as we can in terms of patients and procedures out of hospitals, while still obviously everyone is going to need to take heart to the public health measures, physical distancing, masking, cleaning, all those things. However, hospitals represent a significant bottleneck. So before the pandemic, cataract surgery and fertility services were two services for which the NLMA had begun to work with government on moving them out of hospitals to clinics in the community. Both of those applications are stalled, and this, to me and to us, represents a good opportunity to accelerate what had already begun as work moving procedures out of hospital, if at all possible.
Thank you. Do we have any other questions from any reporters on the line? There is a message box next to the webcast where you can submit a written question. We'll give it a minute to see if we get any questions come through. Our next question is from Peter Jackson of the Telegram. Can you give an estimate of how long a 6-month or a 1-year wait time has increased under the current situation?
I am going to have to, that's going to be very specialist specific. And it's going to depend as well on the urgency of the case. Not to put anyone on the spot, but I think maybe I'll turn this to Dr. McGraw to give it a shot. But I can definitely say that the very long wait list is unwieldy, and it's difficult to give specifics on specific cases.
So thanks, Dr. Fitzgerald. That's a great question. And I think we already mentioned about how patients are classified as to the urgency of their procedure. So, I mean, we do a large volume of procedures in Eastern Health related to the digestive tract. It's upwards of 20,000 a year. And those patients would be classified into different categories. To keep it simple, they'd be given a number of 1, 2, 3, or 4. And so, for example, the most emergent, which someone shows up in the emergency room, that would be done same day, or they'd be in the hospital and it'd be done within a few days or that week. We've continued to do that, so that hasn't changed. For patients who are labeled as urgent, we like to get those done in a 2-week period. And when we initially restarted back in May, we looked at the surgical patients and we looked at the gastroenterology patients, and we said who was classified as an urgent and who got delayed, and we actually cleared that backlog. Fortunately, there's not a lot of what we would classify as urgent patients. Those would be patients with life-threatening symptoms or abnormal CAT scans, and we cleared that backlog fairly quickly. Our problem is when we get into what we classify as a P2 procedure. Those patients should be done within anywhere up to 60 days, and there's thousands in that category. And this is where someone would at least have to wait an extra 3 months. And because, we're only at 50 to 60% capacity, that just continues to snowball effect. So someone who was booked in March might get in July or August, but then I still had procedures booked into May. Those people now might be looking at October or November. And then there's the backlog of referrals that need to be dealt with. So those patients we would have aimed, so say a referral came in April, that might not even been seen yet. It's been triaged, but they might get seen in August sometime, and then they might not get their procedure until January or February next year. So there's really this funneling where people who have urgent procedures are taken care of, but those who are in that P2 category don't get looked at until much, much later. So maybe 3 to 6 months beyond where they already would have been. Then there's the other 2 categories where it's for screening or follow-up procedures because they've had lesions in the past. And we're really not in a position where we could even look at those patients at this point in time. So they might face delays of 6 to 12 months or even longer, depending on how many more waves or slowdowns we have to face through the fall and winter.
Thanks, Dr. McGraw. I'll just turn it now to Drs. Dobbin, Bridger, and Johnston. If anyone would like to jump in with a story they have around how wait lists for those, someone waiting 6 months, what would that turn into in your neck of the woods? Might call on you, Dr. Dobbin, first.
I also do endoscopy like Dr. McGraw, and I would agree that the P3 and P4 cases they're not even on our radars right now to be doing, because patients that are P2 are symptomatic. So I actually have specifically sent a note out to my family doctor colleagues to say that if you have patients in your system that they're already on our list and they're starting to have some symptoms, you need to let me know, because those patients are not even anywhere close. So I would think that waiting list is going to be extremely lengthy. I would like to speak to probably the orthopedic situation, because I work in a hospital where we have 5 orthopedic surgeons working. So they would generally do anywhere between 8 to 10 hips or knee surgeries, replacements in a week. And so right now, we're probably starting to do 1 or 2 a week of those. And so we're already behind from March 17th for that. And so while those patients don't necessarily have something that maybe take their life, it's a significant effect sometimes on patients' quality of life and on their ability to work. So those patients, their waiting list it's just unfathomable to me. I think some of those patients be waiting well over a year because, again, just like Dr. McGraw said, we still have all the urgent stuff that still keeps coming in. So right now, where we're so limited in doing just our urgent things or our emergent, then all of a sudden the OR time that's available to us is just so little, and the amount of beds that are available are just so little that these kinds of cases are pushed out and pushed out and pushed out. And again, as a general surgeon, something simple, that sounds simple, but maybe someone having a hernia done or hemorrhoid surgery, like right now, hemorrhoids, you sort of think, that's not very tasteful, but you know what, people are really, really suffering with those. And it's the kind of thing that's just not even on a radar to be done right now, because there's just, you have other things that are life-threatening or may potentially cause the increased morbidity in that patient or unwellness in the last 3 weeks. But those patients are really suffering. So I think those patients, unfortunately, their wait lists are extensive. And again, just like as Dr. Johnson said, as we get that other next wave and we don't have a chance to sort of catch up on some of that stuff now, when the next wave comes, those patients will be just pushed out that much further again.
Dr. Johnston, comment?
Yeah, I echo what Carolyn and Jerry are saying. It's hard to explain sometimes the way wait lists work. I guess the simplest way to put it is if you have something very scary and urgent, it will still get dealt with. And then there's a second category, which is basically like a P2-3, which would be something that we need to get to, but we're not going to get to it yesterday. Those would have waited several months. At this point, it'll be several more months than that. And then there's patients who have a legitimate problem that needs to be solved, but they're going to have to wait for those other categories. Those would have waited 6-12 months. Now we're looking at 12-18. These are just sort of ballpark figures. And that will get worse the longer this goes on, or if another wave hits. We have a lot of work to do that we're not getting to.
Dr. Pritchard?
Thanks. Yeah, I'll just echo what the others are saying. And in pediatrics, it would really depend on the specialty or subspecialty. And we're certainly with children, you're doing every emergent and urgent case. You had to keep up on those. But everyone else is definitely would be pushed off several months, some more than others, depending on the subspecialty you're talking about.
The next question we have is from Kelly Ann Roberts of NTV. She's asking, what would you like to see the government do immediately?
Well, thanks for that question, Kellyanne. I think what we're interested in is some real tangible cooperation with the government, with benchmarks and a plan. We're calling on the government to come up with a plan on how they, with the regional health authorities, are going to get through this backlog, and also share that plan not only with physicians and other insiders in the healthcare system, but importantly with the public. We have some best practices to look at in Atlantic Canada alone, where there's real transparency on how this problem is being addressed. We're just not seeing that here, and the inclusion of physicians who are lying awake worrying about their patients on wait lists would be very helpful.
The next question we have is from Elizabeth Witten from All Newfoundland and Labrador. When will you be reaching out to the Minister of Health next or meeting with him?
We have no particular meeting planned with the Minister of Health at this point. Our door is always open and our line is always open.
The next question we have is from Mark Quinn from CBC. What, in your view, has the province failed to do to reduce the backlog?
Well, I think the transparency has been a real issue, as well as keeping a finger on the pulse regarding disease prevalence and the time to ramp up. As some of my colleagues have already mentioned, there are other provinces that started to open up earlier, that began to see that disease prevalence was low and that this was a time to kind of sneak in before second wave, etc. So those would be, as far as the timing, that would be one of the missed opportunities. As far as relationship and healthcare organization. Another missed opportunity would really be around dialogue with the physicians who have the patients waiting, and work together on that. I'm not sure if there's anyone else who'd like to chime in with their perspective on missed opportunities. So we'll go to the next question.
The next question is, can you elaborate, sorry, I should back up. This is from Brian Medora from VOCM News. Can you elaborate on Dr. Johnston's comments that the list to be done is being selected for him? Is this happening with other doctors? And what is the normal procedure?
I'll just turn that to Dr. Johnston for reply.
Yes, that is no longer happening. But in the early phases of the pandemic, when things were essentially on lockdown, if you wanted to do any operations that were not life-threatening within the next, hour or so, you had to submit patients and the procedure you were going to do to an OR committee, which would then review your patient and the case and the suitability of getting the case done now as opposed to at some point in the future. This list was then sent further up the rung to various levels of government before things were finally okayed and allowed to proceed. I understand that in the early phases, things were very scary with regards to where COVID was going, and it made sense to be very careful about what kind of risk we were putting healthcare workers and indeed the public under by proceeding with certain surgeries. But as things have moved beyond that phase, I think it's important to, in a similar fashion, move beyond the phase of that level of oversight. And thankfully now that's no longer happening.
All right, the next question we have is from Kellyanne Roberts from NTV. Knowing the measures were initially taken with the interest of protecting as many as possible, but as we now move through the alert levels and the system is held at 50%-ish, is there any way to break down or explain the damage the COVID-19 measures may have caused to the patients, for example, worsening conditions?
Well, it's, that's very difficult to do. What are the things that didn't happen? What are the things that went longer? And obviously the data is something that will be gathered 5 months, 5 years from now. What are the things that had they been hit earlier would have been caught? So no, I can't give you specifics right now, and I don't think anyone could on missed opportunities and the actual cost. But when we see the waiting, and the other thing that's happening now as we open up is there will be more new diagnoses because we're starting to see more clinical patients. So we're talking about the backlog. The backlog we're talking about now is the one that really has existed since March. That wait list is going to start to grow as people like me see patients in the clinic and look at them and say, you don't look as good as you did 4 months ago. I'm just going to run a couple of tests. Well, that test turns into a diagnosis, and that diagnosis turns into a required treatment. All those waits are really something that we're not even really starting to get even an idea about yet. Dr. Johnston?
Yeah, I think it's important for members of the media to realize that the story of COVID-19 will not be written for another 5 or 10 years. I think it's easy in the initial phases to see this deadly virus, and it's easy to tabulate costs to humanity on that specific front. But if you, as you are alluding to with your question now, there is the remainder of the patient population at hand who is having delays in getting their CAT scan for diagnosis of that mass in the lung and whether or not there may be something somewhere else, delays in getting the biopsy done on that mass and seeing what it really is, delays in getting to perhaps chemotherapy before or after surgery, delays in follow-up monitoring. All of these things add up and it becomes death by 1,000 paper cuts. And what you're going to start seeing is patients with cancer diagnoses, which would initially have been quickly diagnosed, treated and followed up, are now going to stretch out. And these people will lose potentially years of life later on down the road, 5, 10 years from now. And that's not an easy story to write. But it is a real story and part of the unwritten story of COVID. And as a cancer surgeon, I can tell you, I worry deeply about this.
I'll just give anybody else an opportunity if they'd like to speak.
I wouldn't mind just speaking to that. And I think anyone who sort of works in an emergency work, which as a general surgeon, I do a lot, we are definitely seeing patients presenting later with some of their conditions. And then because they're presenting later, sometimes their surgeries then are more extensive, and then their hospital stays are more extensive. So they have a significant impact in that their recovery is longer, and that means their return to work or their return to their normal living is definitely impacted. So I can speak to that as a general surgeon in my own practice and in my colleagues' practice, because we all take care of each other's patients. So I can speak for that. So I know if I'm just seeing that in my little small microcosm of 4 general surgeons who work collaboratively together, I can guarantee you that every other department throughout the province is starting to see that. But the other thing, as Dr. Fitzgerald mentioned, is the impact of things like our screening tests that aren't being done. So our FIT program that Dr. McGraw chairs in terms of stools for occult blood looking for either polyps or malignancies in the bowels, and our mammograms, like here in Gander and Central Health, our mammogram rate is still only at 50%. So, and a lot of malignancies are detected by these tests when the patients don't even know that they have it. So, a mammogram that you're just getting done because you're 50-something years old, that sometimes will pick up things. And that is actually a very common presentation of, say, of a breast cancer, rather than someone actually feeling a lump and noticing it. So, as Dr. Johnson said, because those screening tests aren't being done now, it's going to be that much further out before we start to see that these people are coming to presentation, because they just had to delay in actual accessing a test that was a screening test that we have put in place because we're trying to prevent these patients developing these problems. Women aren't going in and getting their pap smears done. So it's all these things that are happening that we normally do, that what we are doing to prevent people developing illness that we're not having the opportunity to do right now. So that's impacting what we're going to see down the road as well.
Dr. McGraw?
Yeah, I've also noticed, I've done a lot of virtual care over the past 3 months with my patients, and I'm often surprised. I'll call a patient who has Crohn's disease or ulcerative colitis, and I'll say, how are you doing? And they'll say, well, I'm just sitting here at home. I'm afraid to go to the hospital. I'm moving my bowels 10 or 15 times a day, and I'm passing blood with every bowel movement, and I can't sleep because I'm up 2 or 3 times a day to move my bowels at night. And I'm there, well, you should have called me, or you should have went to the emergency room, or you should have contacted your family doctor. But a lot of people out there have been scared to do those things. And I think we're going to see this sudden burst of people who are unwell over the summer. In my field, it would be patients who have inflammatory bowel disease. And there's a lot of patients who've been ignoring these symptoms because, they're afraid to contact their doctor, or they're afraid to take their regular medications, because a lot of the drugs that I use, I'm one of the people in this conference who doesn't do surgery. I use medical therapies to treat these drugs or diseases, and patients will often be afraid to take those drugs because they suppress their immune system, and then they're afraid they'll pick up COVID. And that's a concern. But I mean, we've had infectious diseases for as long as there's been human beings. And patients, if they need medications, they need to take them under the care of a specialist like myself, with the help of their family doctor to look after infections that come up. And they need to know what they need to do. So by all means, they should, let one of the physicians in their realm of care know if they're not well, or if they're going to stop a medication because they're scared they might get something. They also need to discuss that with their physicians.
Okay, unless anybody else would like to have something to say, I'll go to the next question. Okay, the next question is from Kellyanne Roberts from NTV. What can the public do to help?
Well, that's a good question. When you're waiting, I think it's important that you contact your healthcare provider, your physician, and your regional health authority, and ask them about it. if you're waiting and getting sicker, we need to know for sure. Those examples that Dr. McGraw just gave are a little bit on the worrisome side. So certainly worsening symptoms, the public, the patients need to tell their physicians when they're getting sicker, so that we can reprioritize and ensure that they are at the right level of the waiting list. Things change, and we don't know that they're changing unless the patient tells us. But we are calling on the government to make some changes here, to be transparent. And I think everybody wants to know where their father, where their brother, where their sister is in line. And until we get that kind of information, people will be wondering. So we're interested in working with the government, and the government is all of ours.
I wouldn't mind speaking to that if you don't mind. A lot of care that we provide now in healthcare, popular lingo right now is patient-centered care. And we want and so because of that, in a lot of committees that hospitals have, we have a lot of patient advocates that sit on a lot of committees. And putting yourself forward to be a patient advocate, to share your experience, is always a very important thing to do, because it helps those of us who are sort of within the system to maybe to understand where a patient's side is, because we're only coming at it from what our side of the system is. But equally, I think patients need to make it known that they're concerned and they're worried. And that needs to be let known at a higher level than the secretary that you're speaking to or the clerical staff that you're speaking to. So right now, a lot of the frontline staff, in terms of clerical staff or booking clerks or admitting clerks, are receiving a lot of phone calls, and sometimes they're angry phone calls, sometimes they're frustrated phone calls, sometimes they're very scared phone calls. And those staff are they will turn to us as the physicians, go, I don't know what to do, So, making sure that patients are speaking up, that they're speaking not just to clerical staff, but most hospitals, have a phone number for you to call to say when you're worried about something, if you're at risk or that your care is being impacted. So I think by, making that known and speaking up to that, that's important, and letting your member know, sending an email. Because if you do those things, because right now, if it's the physician and the nursing staff and the people who are the frontline staff complaining, we need to hear the patient's voice as well. And I think the patient's voice is very important. And just on a separate aside of that, your voice in terms of things like your visitation, and I know that you've been very vocal about that as the public. I can tell you, as a healthcare provider in the hospital who has had patients die during this pandemic, it has been a very, very challenging time to have to talk to you over the phone. And so, for those of you who've got people in long-term care homes, I mean, it's so difficult. I can't even imagine what that must be like for families. So you need to speak up, and I know you are about certain things, but speak up about how you're accessing your care, and that needs to happen.
Thank you. And that's it for the questions.
Well, thank you everyone for coming today. We appreciate this opportunity to advocate on behalf of our patients and for the improvement of our medical system. And take care, keep safe.